The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, good day to all you TMD warriors out there. I am Tony Urbanek, and we're here for the next episode of TMD Demystified. Today, we're going to be talking about patient compliance and the protocol of the Urbanek device and protocol. Obviously, if you are a provider of any services to patients, you are very familiar with patient compliance. It has been a problem, and it has been an asset for the medical sciences forever. Today, we're going to discuss that in detail as it applies to the use of the device and the use of the protocol. I will try to make it very direct and very brief, as I always do, or at least try to do in this discussion. But this particular topic and issue actually is another one of those that is extremely important to the full utilization and success of the service, the device and service. So let me back up a couple steps. I've touched on this on several other episodes, but just touched on the concept of compliance and the concept of the protocol. But the protocol is an integral part of the entire treatment process. Let me grab the model here again. So here is our nice model of the device in the mandible, or excuse me, in the maxilla, the Urbanek device. It just happened to be a U. Didn't intend it to be that way. Just happened to turn out that way. But there's a lot of misunderstanding among the patients that we see. I can't tell you the percentage, but a lot of misunderstanding. When they come in here and they hear about us or they're referred in by us, some of them get on to see on the internet and look at Dr. Google before they come in and look at our experience with the process. The point is, a lot of the patients think when they come in and they listen to a consultation and presentation about what it's all about, they think they're buying a widget, piece of acrylic and some ball clasps or some C clasps. They're not. Obviously, hopefully to you, that isn't what this is all about. We're not selling widgets. We're not selling retainers, although it looks like a retainer, admittedly. We're selling a service, and the second most important part of the service is the protocol as to how it's used, the protocol. So when I'm talking to a patient, I always make sure that they understand that I consider this little thing a tool. And that's what I refer to it frequently. I can call it a device. I can call it a splint. But when I'm talking with a patient about it, I prefer to kind of use the term tool. And it gets across the concept that, if you have something that needs to be done and you have the proper tool, you will get from A to B a lot faster and a lot better. And if you don't have the proper tool, you won't get there. So sometimes I will actually hold this in my hand and I will look at the patient and say, consider this a tool, just like a screwdriver. And if you're trying to put a screw in and you're holding the screwdriver at the wrong end, you'll never get the screw in. Maybe a bad example, maybe a bad analogy, but I use it. But the concept is there. This is not what we're selling. This is not what it's all about. This is just the tool we use to get the results, which is the diminishment of the symptoms. So just starting out with that as a point, the point is that the protocol that goes along with the tool is very important. Just like, you know, if you put a screw in, you put it in clockwise to put it in and counterclockwise to put it out. That's the protocol for putting in a screw, using the right end, the correct end, the handhold end of a screwdriver. And of course, using adequate pressure on it. That would be the protocol as to how to put a screw into a piece of metal or a piece of wood with a screwdriver. All right, so this little device has been worked out right from the beginning, from the first one I ever did, and worked out the proper protocol to use it. Now, the protocol is where you run into problems with compliance, because the device itself is designed in the same way for each and every patient as is specified in our online course and in many of the episodes, how it's designed, how it works, why it works, etc. That's in stone, how the device is made and what happens when you put it in. What isn't made in stone, and that is how the patient complies with the protocol. Now, the protocol we've talked about in technical terms. The protocol is, we found best to start out very strong using the device in the mouth 24/7 for the first 2 months, except when the patient eats, and then almost always going to nighttime only after that. That's the technical part of the protocol. Indefinitely, nighttime only. And what we have found after thousands, it's probably approaching 4,000 patients now. I keep saying 3,000. That was several years ago. We counted them up. But thousands of patients who go through the device, using the device and protocol, do best 24/7 for the first 2 months, then nighttime only indefinitely. And then 15% of the patients find that they need to wear it more during the day, another 6 or 8 hours a day, or under times of stress, or what I hear most frequently from the ladies primarily is, I figure it out when I'm in traffic, when I figure it out when I'm on the computer, I put this thing in my mouth. In addition to wearing it every night for sure. That is where you have no control over the bruxism at night. So that is what we found over 11 years and 3,000 plus numbers of successfully treated patients using the protocol. So, but what we're here to talk about is compliance with the protocol. I want to make a few points. I think it's very important because if you think, and you are a provider of this service and you are on our network already, or thinking about being on our network of providers, or want to learn more about our network providers, or you're not interested in being a network provider, but you provide any other service to patients, you are going to be confronted with the patients following your protocol for whatever services you're providing. Obvious. But there is where the rubber meets the road. And after being a practitioner myself for 46 years now, seeing patients eyeball to eyeball, elbow to elbow, getting patients compliance is not always easy. On the other hand, that's part of what I'd like to say from the get-go here, and that is in our practice, in our service, which is now absolutely totally limited to the non-surgical treatment of TMD. I've totally devoid myself of any time spent on doing any kind of office or hospital oral and maxillofacial surgery, and now devote all my time to non-surgical TMD patients and running our company, TMJ Services. But with all that experience, I can absolutely say that one of the bright parts of doing this for patients is that the vast majority of patients are very compliant with following the protocol. And that's heartwarming and actually makes my life a lot simpler. In fact, I gain and have seen patients much more agreeable to following the protocol that we lay out for this non-surgical treatment of TMD than I did even with my surgical patients, whether it be hospital surgery or office surgery, wisdom teeth, especially dental implants. I don't want to go down that rabbit hole, but in the surgical realm, patients do not always follow the protocol and what you ask them to do. And what I found is that in the non-surgical treatment of TMD, and this is my opinion, I think because they really want to get out of their pain. And most of these people come in because of pain associated one kind or another. A few, their primary problem is not painful, but it could be tinnitus, fullness in the ear, subjective hearing loss, vertigo, or locking. And pain isn't a major issue with them, but the majority, like 95% or more of patients come in because they want to get out of their pain. Headache, earache, jaw pain, neck pain, upper shoulder pain, etc. And that's the driving factor. And because pain drives, I think we get a higher level of compliance with our patients who really, and when you lay it out for them and say, it's pretty simple, 24/7 for 2 months, we'll follow you along. At 2 months, you usually go to nighttime only, and then nighttime only for the rest of your life. Possibility you may need to wear a little more during the day when you're in the car, in traffic, something like that. So that's the good part. Let's say that first before I go into the non-compliance. And you have to kind of roll with it, the non-compliance, and we'll talk about that in detail. But let me just talk a little bit more about the compliant patient. They're so easy to work with, and they are in the vast majority. I would estimate, this is my estimation in my practice here in 2022, I would say that at least 95% of our patients follow the protocol almost to the T, almost exactly. And when they don't, they're pretty honest about it. And that's nice, because that's all I want to know if they're compliant or not. Because when they're compliant, we get really, really good results. And when they're not compliant, we don't. And it's just that simple, because the device is works on the amount of time that it's in your mouth and being used, the amount of time you're unloading the joint and allowing the inflammation to decrease within the temporomandibular joint. So compliance is extremely important with success. So we have high levels of success because we have high levels of compliance. I would estimate 95% or better of our patients are highly compliant. Now, just carry that forward just a little bit. There are patients who are very honest and they say, there were 2 nights where I forgot to put it in my mouth. Or one night I woke up and I thought I had it in my mouth when I went to sleep, and it was on the nightstand when I woke up in the morning, and I don't remember putting it there, or stuff like that. That is not what I call non-compliance. Those patients are trying to be compliant. They know what they're supposed to do. And you forget, the most common one I probably hear, and it is the most common, I took it out of my mouth to eat, and I had my lunch, and I forgot to put it back in until 4 o'clock. And again, the patient is not being non-compliant. The patient just forgot. They got busy with their day, they went on with it, they forgot to put it in their mouth. No problem. I expect it. And those patients, that 95%, do extremely well. The only difference with patients, as I see now, and I mentioned it today as seeing a patient, I mention it often, but I remember saying it today. The only difference that we see with patients is how rapidly they move through the protocol, how rapidly they get symptom relief. Not everybody gets 95% symptom relief, symptoms gone in 3 weeks. Not everybody is there. The average is 70. At 3 weeks, the average number is 70. But the difference is that everybody moves through at a different pace, and some people have relief of the symptoms faster than others. And each of the symptoms go down at different rates. So you'll get, in some people, the headache goes away faster, and some people, the neck pain goes away faster if they have both of those going on, etc. All right, so fortunately, 95% of people are really compliant, and that's a joy, and it just makes my job really easy, and hopefully would make your job really easily. And if you're not getting those kind of results from patients, and you're doing temporomandibular joint non-surgical treatment, then you probably need to rethink what you're doing, because we do. Now, here are a couple points about patients that lead to non-compliance. Now, part of the compliance is doing the protocol, and part of the compliance is follow-up, actually doing the steps of the protocol and doing the follow-up. So we ask the patient to come back at 3 weeks after device delivery, and then 6 weeks after that, which is now 9 weeks after device delivery, which is 2 months, and then 2 months after that, which is 4 months after delivery, and then try to get them back at 6 months after delivery. And we hardly get to do that, because by then, by usually well before 6 months, usually well before 4 months, I'm happy to get them back at 4 months and go through the first 3 steps. Because early on, once they get to the point where they're happy, and put a number on it, I kind of quantify that as when the patient can honestly say that 85 to 100% of their symptoms are diminished or gone, then I'm satisfied as long as they're stable. In other words, continuing on, not just a one-on, but they can consistently say that 85 to 100% of their symptoms are diminished or gone for a month or 2 or longer. But once the patient, they're at home and they're watching TV at night and they're not having the headaches anymore, and then they consider, I'm fixed, I'm fixed, I'm fixed, I'm fixed, I'm fixed. And that could be 2 weeks after delivery, or 1 week after delivery, or 3 weeks after delivery, or whenever. And once they get that, I'm fixed, we can't get them back in the office. I mean, you call them up. No, I'm cool, I'm good. Which is unfortunate, because we like to track the patients. We love to, once we get to the point where they say 85 to 100% of their symptoms are diminished or gone, we always ask for a success story, which goes out to all the doctors that unfortunately misdiagnosed, mistreated, or misdirected the patient, which usually there are many, many of those on that patient's history. And that success story goes out on the internet, and other people realize that there is a solution to this problem. But back to compliance and non-compliance, that's one of the big things. They get, I'm fixed. And although I tell them from the get-go, it's a process. We want to see you back until I feel comfortable that you're stable and that you've got all the benefits of your treatment and what you paid for. I want you to be absolutely sure that you benefit by what you paid for. It's not infrequent. Again, I haven't tracked the exact numbers. It'd be a great challenge to do, and it'd be easy to do, except we here in this practice and in this part of the business, we have so much going on. I haven't had time and spent the energy to do that kind of tracking, but I can say that honestly, that probably 50% of the patients after 2 months, you're not going to get them back. And they're invited to come back. It's like, there's no charge to come back. I tell everyone, come on back. If it gets loose or uncomfortable, they loosen up, they do. And fortunately, it isn't really frequently, but they do loosen up, especially if you bite them in place rather than put them in with your thumb. You're supposed to put them in with your thumb, not bite them to place. They get loose. You bite them in place, they get loose, and come on back, no problem, no charge. I'll tighten it up for you, no big deal. Can't get them back. So, they get non-compliant because they're fixed. It's kind of a good thing, a good non-compliance, if there's a good non-compliance, because they will come back. They will definitely come back if they're hurting, definitely. And the only people we get back are the people that either quit using the device. We see those, actually, they just quit using it and say, I'm starting to hurt again. Or people that lose it or break it, which is very common. We had 2 today. 2 this morning came in. They don't have the device anymore. They're starting to get symptoms again. Now that's not non-compliance. They just lost it or broke it, and then they couldn't use it. Now they're back in for a second one. All right. So I mentioned that it is important that I and my associate and all the doctors who are in our network take it to heart, take it seriously, that we really want to make sure that the patient is stable before we discharge them. It isn't just you get them there and they go, okay, I'm 100%, none of my symptoms are there anymore, 100% gone. Well, that's nice. But if that happens too early, and it's common. They come in at 3 weeks and they say 90, 95, 99% of my symptoms are gone. And I make sure I emphasize, well, that's wonderful. You're doing really well, but I want to make sure you're stable and that this thing doesn't recur. And that's why I need to see you back. Some people understand that, some people don't, but I already said that 50% of the people, once they get to the point where I'm fixed, you're not going to get them back in the office unless they lose it or break it. Again, that's really not, that's not non-compliance to what I'm talking about. That is compliance to the point where they're happy with what happened to them, happy with the device and protocol. And you can use happy, satisfied. They got their money's worth, and I just always want to make sure that they are satisfied because we always deliver what's promised. So we want to make sure the patient understands that it works and they've gotten the best benefit. Now, let me digress for the rest of this and talk about the non-compliant patient. Again, like I said, they're the ones that are frustrating. They're the ones that, as whatever you do for patients, you understand that the majority of your patients take the least amount of your time, and there's a small percentage of patients that for one reason or another take up most of your time. That's just the way it works. That's the way it worked in medicine. That's the way it worked in dentistry. That's the way it worked in oral surgery. You know, you go around taking out wisdom teeth, kapakata, 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 and then all of a sudden you get one patient that's going to take up a whole bunch of your time, while the other patients take up very little. Well, that's the way it is with non-compliance. The compliant patients take up very little of your time, and the non-compliant patients take up a lot. Okay, so let's kind of focus in on non-compliance. I would estimate, just my estimation again, that the truly non-compliant patient who comes to see us for TMD, TMJ complaints of any of the varieties make up no more than 3% of the patients. Now, you'll get different personalities in that 97%, all kind of different personalities. I like that. Let me digress for a minute. I want to make a point here. I'm going to make a point for anybody young and old who practices healing arts. When you're talking to a patient and you want to do your best with them and for them, meet them on their level, on their personality level. Meet them where they're coming at you with. And what I mean by that, if I'm being vague, I'm not trying to be vague. If you have a very, let's start out in a best way. If you have a very happy patient, if you have a patient who had one today who had a great sense of humor. And she said, you know, not everybody appreciates my sense of humor. I noted it right away. I told her, I said, you have a great sense of humor. And she said, thank you. Not everybody appreciates it. And okay, I can have that. But the point is, if you have a patient who has a good sense of humor like that, meet them on that level. Be humorous with them. You can do that. You're safe being humorous with that patient. This is self-evident. This is obvious sometimes, but I can tell you that practitioners don't practice it. This is freebie. This just doesn't have anything to do with compliance. And I don't want to spend too much time doing this, but it's a point that will help you a lot. I'm here to help you. I'm here to help you no matter what I can do. So if you have a patient who's good in humor and kind of joking around with you, then you're safe and appropriate to be humorous and joke with them. If you have a really serious patient who really is looking you at the eyeball like you might have horns, then you need to kind of meet them on their own level, and you need to meet them in your discussion the way they're discussing it with you. Now, there's an art to this. You have to practice it, and it's fun practicing it once you start doing it. But because of that, if you meet them on their level of communication, you will be more real to them. You will literally be in communication with them. They will listen to what you say. What you say will be more meaningful to them because you're meeting them on where they live. If you have another example, if you have an antagonistic patient, fortunately, they don't come in very often, but I've seen it. They're just antagonistic. I don't know whether they're antagonistic just for this moment, just for this appointment, or they're just antagonistic all the time. But you know what? I meet them down there in antagonism. Now, I don't try to insult them. That isn't what I mean. But if they're antagonistic, I'm going to go down to almost where they are and meet them on their level. And again, because of that, you're more meaningful to them. They get it. That was a freebie. Just think about that. Try it out sometime. When you have, especially one of those difficult patients, kind of where is this patient in their communication level? And you go down to meet them there. And wherever that is, high, medium, low, skepticism. You can recognize that one pretty easy. When they're skeptical, you kind of know. You just got that, oh, this patient doesn't even think that I know what I'm doing, or this isn't going to work, or this is the wrong thing. So meet them down at skepticism. Be honest about it. Use the word skepticism, that you recognize that they're skeptical. That's an easy way to do it. Yeah, I see you're skeptical. Oh, yeah, are you skeptical? Well, yeah, whatever. Try it out. It'll work. All right, so back to, in the last few minutes here, unfortunately only take a few minutes, the non-compliant patients. Why are patients really non-compliant? And they do it, and these are the patients that kind of do it intentionally, not unintentionally, not leaving the thing on the bedstand. They do it because they're non-compliant. So what are the major reasons for non-compliant, or at least the ones I can think of today? There are probably many, many, many more that I don't think of. But and keep these in mind as you deal with this last 3%, remember, that take up most of your time, the non-compliant patients. And then I'll make a point at the end about the non-compliant patient. Very important point at the end about all of the non-compliant patients. So there's a non-compliant patient who feels that they know better than the doctor for whatever reasons. They know better. They've been on Dr. Google, or they're just smarter or whatever, and don't take it personally. And it's not an affront to your own intelligence. They're just, they're going to use it the way they want to because they know better for whatever reason. They read something, they heard something, they just know better than the doctor. And so they're going to be non-compliant. There's the non-compliant that is used to doing just as they please all the time. No matter, if when they were a kid, if the mom showed them how to dry dishes, they'd figure out some other way to dry dishes than the way the mom showed them how to dry the dishes in the kitchen. And that's a different kind of non-compliance. They're non-compliant because they're going to show you that they can be different. It's like, okay, it's one of those personality defects, I guess. They're non-compliant patients who are non-compliant because they're comparing what you give them to do as a protocol, something to do. These are the instructions. They're comparing it to something else similar, or something else that they heard about that had different instructions. And they do it intentionally. They take your device, which has a protocol to it, which I've explained, and then they use somebody else's instructions on it. It's like, and I won't go in, you can imagine, I guess the most common one is, well, my doctor said I had one of these 10 years ago, and my doctor said they only had to wear it at night. Okay, well, this is going to be a non-compliant, if they admit that right up front, this is going to be a non-compliant patient, unless you fix that right off the get-go. The answer is, this is not 10 years ago. And obviously it goes into what I said before, meet them on their level. This is an antagonistic patient, be an antagonistic level. Well, this is not 10 years ago, and this is a different device. and then wait for their response. You're being antagonistic back to them when they're antagonistic to you. There are ways to handle the non-compliant patients. We'll talk about that primarily at the end here. But that's another non-compliance. They want to compare it to something else that they heard or told and take your instructions and mess with them, screw them up. Obviously, they're not going to get the result. To get the result, you have to do the protocol. It just worked out that way. Non-compliance, you have patients that are just used to not following directions. I don't even know where to categorize if there is a category to put them into, but there are people that I have seen that they're just not used to following any directions. They're just used to, like, kind of goes into doing whatever they want. But those people, it's that, you know, the people just used to doing whatever they want. They know they're used to not doing what they just used to not doing or doing whatever they want. The category I'm talking about is patients that just can't follow directions. What kind of mental disorder that is, what kind of personality. I'm not a psychologist, psychiatrist. I'm not going to go into that. I'm not sure. It can be categorized, but I've seen that. They just can't follow. And, you know, that would actually, you could categorize, and I've seen that often, and that's a different story, but the patients who have mental disabilities, an actual disability, and you can't hold that against them. But they're the ones that's one part of this, that they're not going to follow a protocol because they have a mental disability. But those are recognized. You know, when you're talking, mom brings the child in or the adult in, mentally disabled, you know you're talking to a mentally disabled patient and you're not going to expect them to follow a protocol. That's not the category I'm talking about at this point. Category is people who just can't follow directions. And to you, they're kind of normal. Their communication is okay. They communicate kind of normal, but you're going to find out they just can't follow directions. And so I guess you could categorize them as have some kind of mental disability. The second to the last one I want to talk about is the emotionally charged patient. Or I'll take that back. Let's talk about the patient, non-compliant patient who claims the device causes them to gag. This is really uncommon, but I'm going over the ones that I could think of today and really got down to the bottom of the barrel. We've delivered well over successfully 3,000 cases, going on 4,000 cases of that device in the mouth. And in that 4,000 cases, I can only remember 2, maybe 3 of 4,000 who had any kind of comment that it caused them to gag. And two of those, after I explained the gagging reflex and how the gagging reflex works, and it's only at the soft palate, and if you breathe through your nose, you'll cut off the gagging reflex, and it is a reflex, and people do experience gagging when there is pressure on the soft palate, but that this device doesn't even come close to the soft palate. And those 2 out of the 3 patients, they're the only ones I can remember of 4,000 people. Rapidly got, well, doesn't gag me anymore. Good. But just recently, I had a patient come in and her claim was, and I wonder whether this was a valid claim or not, because it's so rare, but her claim was she put it in her mouth and all she could do was vomit. And I took her through the gag reflex and how it works. And if you breathe through your nose, you short circuit the gag reflex. And she was just adamant that when she put it in her mouth, it caused her to gag. That was just recently. I mean, literally within the past month. And it's the only one I can remember. And I finally gave up. And I said, okay, I got it. It makes you gag. We have a policy in this practice. If the patient cannot use the thing, I mean, if they don't find it effective and they can't use it, we refund 2/3 of the fee. It's just right off the bat. Simple. So I just refunded her and took her device and said, sorry, I couldn't help you. But the point is that I don't think that this was actually a valid reflex. Could be wrong. If it is, it's the first one I've ever seen, so I wouldn't claim that it can't happen. Wouldn't claim that, but 1 out of 4,000, those probabilities are really, really low. So can happen. Kind of look for it or wait for it. Probably wait a long time. But that brings me to the last one before I make my last comment about all this, and that is the emotionally charged, the patient that has emotional charges on the oral cavity or anything in the oral cavity. If you're a dentist, you've probably seen 1 or 2 of these people. Maybe not. I certainly have. I definitely, fortunately, it's very uncommon. But these folks have some emotional connection, emotional charge, which is doesn't have anything to do with you being a dentist, being an oral practitioner, putting some device in their mouth or doing something in their mouth. They just have some unwarranted, unexpected, unexplainable to us emotional charge on devices or anything else going in to the oral cavity. And those patients can be very non-compliant. They can be very non-compliant. Fortunately, they are really, really rare. They're the rarest of the rare. Of the 3% that I would call non-compliant, they're in 1/10 of 1% of the 3%, which puts them like 0.0003% of the patients. Maybe it's 0.00003% of the patients. So unfortunately, it is not common. But again, I've seen it. I wanted to talk to you about why it's important for the patient to be compliant. I think I covered that pretty well. You don't get the results unless you're compliant. And then emphasize the patients that are compliant, which is the beauty of it all, thankfully. And then spend a little time on the non-compliant patients, which are very small percentage, but take up most of your time and anxiety and wondering whether you're doing the right thing. And understanding them to keep your own ship upright and make sure that you understand what you're doing is for the patient's best interest. So the last thing I'd like to say about the non-compliant patient is this: that last 3%. Don't be afraid at all if you have a non-compliant patient, to the best way you know how. I can tell you how I usually do it. Fortunately, it doesn't happen that often. But just say, ma'am or sir, I don't think I can help you. And that's all you have to say. And again, this is free advice. I learned this, I don't know the hard way, but I learned it well by experience. That's all you have to say. Don't try to say anything else, and keep saying it. Just keep saying it. You don't have to make any comments of justification about what it is. You don't have to say anywhere else they need to go. You don't certainly make any comment about their own disability or their own personality. You just keep saying that, sir, madam, Mrs. Jones, Mr. Jones, it's obvious I can't help you. And then you'll usually get a lot of this for a while. And then when they get quiet again, then you repeat yourself. That's the point. Just keep repeating it. Mrs. Jones, I really don't think I can help you. And one way or another, they will finally, it might take 2 or 3 of these cycles. It might take 10. I don't think we've ever gone any longer than 2 in my entire career. And I only had to do this 2 or 3 times, maybe 4 times, 3 times in my career, where I just kept saying, Mrs. Jones, I just don't think I can help you. And they finally get it. And they leave one way or the other. That's how you do it. And don't be afraid to do that with the non-compliant. That's the point. Do not be afraid to do that with the non-compliant patients. They're not going to help themselves. You're not going to be able to help them. They're only at most 3% of the people that you see at most. And even most of those 3%, you can get them through their own stops and barriers. But when you have somebody that is just not going to be compliant for whatever reason, don't be afraid to say, look them in the eye and carefully and slowly say, ma'am, sir, I don't think I can help you. I just can't help you. And that solves the problem. It's all about solving problems. That is what I have to say for today. I hope it helps. I hope it's meaningful to you. It comes from the heart, and it comes from long years of experience dealing with people in pain, and especially people with temporomandibular joint pain, which fortunately we have the solution for, and it is predictable, well studied. We now have our study complete. I think you've heard about all that, and I encourage anyone who wants to do this for their patients, for their own practice, for the benefits, for the financial practice of your benefits, for the benefits of your patients, for the millions of people who get misdiagnosed, mistreated, and misdirected all the time regarding their temporomandibular joint symptoms. This is a great opportunity to be a specialist in your vicinity, in your market, in your city, town, that can really solve this problem. If you'd like to do that, you can learn more about it and what we do on our website at www.tmjservices.net. I can be reached at tony@tmjservices.net. Our Director of Marketing and Education, Naomi, can be reached at naomi@tmjservices.net. And I encourage you to get involved if you'd like to help other people with temporomandibular joint disorders. So for today, that'll conclude this episode. I look forward to speaking with you at the next opportunity that I have, which will be on a weekly basis on Dental Town and our podcast, TMJ Demystified. I will talk to you soon.